We could talk about that a lot longer. To stay on the topic, I thought we would talk next about comparative effectiveness. It fits into this discussion because it's thought that it will shine a light on things that are unnecessary or too costly, and it's a big concern to industry. Industry is hesitant to ever do head-to-head trials, and so I thought that we could have Dr. Sacco talk about some comparative effectiveness, and then maybe even discuss a specific example of carotid stenting versus surgery. So if you want to begin there.
Sure. I think under both the Affordable Care Act and under the ARA funding, comparative effectiveness research has really taken a big step up. There's nothing new about comparative effectiveness research. It's been around for a while. It is a way of trying to compare alternative methods in both the diagnosis, prevention, and treatment, both the risks as well as the benefits. And there's a variety of types of comparative effectiveness research that exists. Randomized trials are the ones we think of the most. They can be costly, but they are the basis of our evidence-based guidelines. But now with meta-analyses and now with registries that can come out of some of the big investment in electronic health records, we may be able to get in real time new information about comparing alternative strategies. So cost is one thing, but I think when you think about comparative effectiveness research, it's really, if anything, mainly geared to inform the consumer, the physician, the policymaker, the system about really quality, what's best for quality. When faced with two alternatives, which is the better way to go? Should we take alternative A versus alternative B, a intervention that could be more costly perhaps to, say, a preventative health approach? So under the Affordable Care Act, the big thing that will happen is they will actually create, mandated, the Patient-Centered Outcome Research Institute. This will be a huge institute to take a lot of this new information, digest it, and make it available to patients, consumers, physicians, healthcare systems. And there'll be a lot more decision support networks and a board of governors to help with this, and an investment in trying to increase the amount of comparative effectiveness research that exists. Because I think we could improve quality as well as perhaps cost when we improve quality. Example, a lot of things that we try to do in medicine are based on evidence-based guidelines. When should we do the CAT scan or the carotid ultrasound in screening somebody at risk for, say, carotid disease? When should we pick a surgical procedure versus an interventional procedure versus medical therapy, which obviously have different cost differentials in somebody who's, say, had an event from carotid disease blockage in the carotid artery? So comparative effectiveness research will help us inform those decisions as well as help us keep our evidence-based guidelines up to date. And with electronic health records, we'll be able to monitor in real time, trying to practice with the guidelines and stick to guidelines as much as possible. So you asked about CRESS. CRESS is a great example. It's a large NINDS-funded trial comparing endarterectomy, a surgery for carotid stenosis, versus angioplasty and stenting. The trial actually showed no difference, but it did show some interesting side points regarding the preference of certain therapies depending on age. People who are younger, for example, maybe the angioplasty and stenting was actually better than the endarterectomy. People who are older, surprisingly, the endarterectomy was a little better than angioplasty and stenting. So this kind of information from big randomized trial or from other comparative effectiveness research programs will hopefully inform and improve quality, and we hope translate into some improvement in costs.
But we have to be careful about that, because what we don't the politics of this is very dicey. It can't be seen as a budget reduction body of research.
We had a panel last year with a senior Johnson & Johnson executive, and it's the number one concern to industry.
But also to the doctors. We don't want our doctors choosing the cheaper alternative. We want them to choose the best alternative for that particular patient. Age may be an issue, but hopefully standard of practice will also at the same time have some kind of impact, because right now we don't have a very clear strategy here. But
we prefer that outcomes drive it, and
right.
We want to get the best that we can for our patients. So if anything, comparative effectiveness research is supposed to tell us what will give us the best outcomes, what will be the lowest risk, but improve the best outcomes for our patients. And the patients and consumers are going to be looking at the results of these comparative effectiveness research studies as well.
We're going to have a special topic just with you all on this, but I'm sure you have
Yeah.
some thoughts.
Well, it's very interesting because what Ralph described relative to the cerebral arteries, is also something that we have seen with the heart. I'm a cardiologist, and so my expertise is in angioplasty versus cardiac surgery. What would be the best procedure for a patient versus medical treatment? And the point is that in general, it's very difficult to establish that one approach is overall better than another. They all have their advantages, they all have their limitations. But quite often what you see is the kind of, side finding that may not have been really the initial endpoint, but something that came up that was a predetermined a secondary endpoint where age is an important discriminant, that you find that an elderly individual benefits better from bypass surgery than from angioplasty, for example. And the challenge really, Steve, is the fact that there is a danger when you try to reconcile all the trials and to generate a general recommendation for the medical field. And that's where Donna is so right, where a one-size-fits-all would be basically imposed because that's the only one that would be reimbursed. You take the risk of the fact that we would have to make some guesses to fill the gaps of things that have not been looked at. And we're not particularly good at that. I'll give you the example of hormone replacement therapy as a preventive mechanism for women and heart disease, where at the time we started the trial with Trudy Bush, I can tell you that everybody thought that it would be a slam dunk positive result. It turned out that it wasn't helpful for women, but instead was increasing risk, for example, of deep vein thrombosis, some vascular events. So, we're going to have to be very careful to not overinterpret the results that we have, and to leave it to the clinician when there is a situation that requires that is in the gray zone and doesn't have hard solid evidence that was generated by a randomized trial prospective that really addressed a specific question that is being